Hi, everybody, and welcome to our virtual conference entitled Mission Possible. And obviously, this is going to be kind of a play on our favorite movies. But first of all, I'm Dr. Jeremy Pettis. I'm an endocrinologist at University of California, San Diego. Been living with type 1 diabetes since I was 15. Joined, as always, by my good friend and colleague,
Dr. Steve Edelman.
Same introduction, type 1 since he was 15, founded TCOYD over 25 years ago. So again, this virtual conference is playing on some of our favorite movies. You know, we did some James Bond things, and we thought, what better way to start the conference than talking about what a transformative year it's been in diabetes. So Transformers, right? We all love Transformers.
Transformers.
Yeah?
I got something for you. Hold on.
Oh, great. This ought to be good. Okay. All right. Steve, that's not even close to the right movie. That's clearly Iron Man. And we're talking about Transformers here. You know, like Optimus Prime and stuff? Yeah. Okay. Okay. So, as I was saying, this has been a transformative year in both type 1 and type 2 diabetes, but we're going to focus for this discussion on type 2 diabetes. And we're just saying, like, we don't have to, like, go finding things, like, really difficult to look for these things. There's so much happening that we just are so excited to talk about this transformative year in diabetes.
Yeah, the hardest thing is to hone it down to 20 minutes.
Yeah.
So what I'm going to do is I'm going to start off just talking about what is type 2 diabetes. It's a group of metabolic diseases that can lead to high blood sugar levels. And the simplest definition is that people with type 2 don't make enough insulin and or the insulin does not work well. And I say metabolic conditions because it's associated with heart disease, kidney disease, and many other conditions that go along with type 2, like obstructive sleep apnea, GERD, which is gastroesophageal reflux disease, heartburn, and you can have congestive heart failure, and when you get heavy, you get joint problems. So there's a whole laundry list of things that are associated with type 2 diabetes. That's why we say metabolic disease. And the other thing too is, when you have type 2 diabetes, you also typically have what we call abnormal lipid levels, high triglycerides, low HDL, high LDL, that's the bad cholesterol, a higher propensity to have clots in your blood. And that's why we commonly call type 2 diabetes a polypharmacy condition, because if you're under good control and you're a typical type 2, you have drugs for your diabetes, maybe pills and injectables. We'll talk about some of the newer ones. Then you might be on 1 or 2 drugs to keep your blood pressure down. And then you got to get your cholesterol under control. And you might, listen, when you get type 2 when you're older or younger, you might have other conditions like arthritis or asthma. So that, unfortunately, when you got diabetes, it doesn't negate the other problems that people get in life. So what do you say to your patients when they come in? They say, Dr. Pettis, I'm on this long list of drugs. I'd like to get off of them. What do you say to them?
Well, first of all, I mean, just listening to you talk, it's just kind of like Jesus. You know, like there's all these things that people have to deal with. And, you know, like you just can probably feel like the deck is stacked against you. Yeah, I have diabetes, but I want to lose some weight. Worried about my heart, kidneys, joints, all these things. People come in and say, yeah, I want to get off these medications. You know, first I would say, I get it. And then I would transition to some of these, you know, exciting things that patients and providers can align on. It's not that we just want your blood sugars to be better for the hell of it. We want your blood sugars to be better so you live a long and healthy life. And a lot of these drugs that we're going to talk about can really help people lose weight. And we're not talking about 1 or 2 pounds. We're talking about a game-changing, you know, lifestyle-changing amount of weight that we're going to talk about.
Yeah, and I think it's important to say now that, and I'll probably repeat this at the end if we have time, that you can live a long and healthy life with type 2 diabetes. In fact, some of the studies show you can live longer than your neighbor who looks like you, weighs the same as you, is the same sex as you, but doesn't have type 2. And so it's important to realize that it's a long laundry list of issues, and don't freak out. They're all treatable.
Yeah.
So the first thing we want to talk about is this new group called GLP-1 receptor agonists. So how would you describe how these drugs work?
Well, it's a natural hormone that's released in the gut whenever anybody eats. And when you eat, it's
So mine goes up when you eat?
yeah. So when
Sounds
you eat,
good.
your intestines sense calories coming in, release this hormone that helps your pancreas stimulate more insulin, so your blood sugars improve. And importantly, it actually works directly on your brain to say, hey, there's calories coming in, slow down, like you don't need to eat so much. So kind of a 1-2 punch of helping your blood sugars, but also helping you eat less so people lose weight.
Yeah, that's important. And Jeremy mentioned it helps increase insulin. And I don't want to get too scientific on you, but it's what we call glucose dependent insulin secretion. That's why people without diabetes can take it and they won't have hypoglycemia. And very importantly, you forgot one of your favorite hormones, glucagon.
Yeah.
Glucagon raises your blood sugar. And the last thing you want right after you eat are high glucagon levels. And for some reason that goes awry in type 2 diabetes, and this also helps to suppress that.
Absolutely. And what you mean by glucose dependent is that it only stimulates insulin secretion when your blood sugars are high. And then when your blood sugars start going low, it shuts it off. So that's why these drugs don't make people go low.
Yeah, it's an impressive class. And they were, believe it or not, the first one was discovered in 2005 from the saliva of a Gila monster lizard. And they didn't know what it was, but they did know that saliva did some pretty amazing things. If you have a Gila monster as a pet. Since that very first GLP-1 called Byetta came Bydureon, and then Trulicity, and then Ozempic and Mounjaro. So we'll talk about those in a little more detail, but these drugs you're replacing a natural hormone.
Yeah, and I don't care if you have diabetes or not, everybody has heard of these drugs now. Ozempic is on TV, the Ozempic, which is apparently one of the most effective ad campaigns in history. And then, you hear about shortages because, everybody in Hollywood is stealing these medications from people with diabetes because they want to lose weight. So this really has crossed over from a diabetes drug to just kind of, it's out there and everybody knows about these things.
Yeah. So the medications, we talked about them. The Trulicity and Ozempic gets a lot of fanfare. And then the recent one is Mounjaro. And I think it's important to spend a few seconds about describing Mounjaro and how it's different than the other GLP-1. So Mounjaro is what we call a dual agonist. It stimulates GLP-1 and another hormone called GIP. Do you remember what that stands for?
Well, first, I think it's important to show people how to pronounce it. I think we have a quick little clip about that. Yeah, here we go. What's it called again?
I'm excited too. It's called Mounjaro.
Wow. Wait, what did you just say?
Jeremy, it's called Mounjaro.
That seems kind of fun. I think I'm going to give it a chance here. Mounjaro. Did it work?
No.
So it helps, to bring them the Italian flair.
I love the way you say that.
Yeah.
But, to help you answer that question, GIP, ready for this? Glucoregulatory insulinotropic polypeptide. GIP is a lot better. But in the clinical studies, they compared it to Ozempic. Now, not the highest dose of Ozempic, so you might say that really wasn't fair. And they compared it to the highest dose of Mounjaro. And Mounjaro led to greater weight loss and greater A1C reductions to the point where 50% of the participants ended up with an A1C less than 5.7. That's the non-diabetic range.
Yeah.
So you and I were talking when data first came out not long ago, is that no one ever reports the data less than 5.7.
Right. They
always say, what percent of people can get less than 7? And in this particular study, Mounjaro, 90% of people. So it's a blockbuster.
Yeah, it's a game changer. Not only are we just kind of settling for A1C less than 7, good control, it's people, half of the people got to non-diabetic ranges, which is incredible. And what about the weight loss? How do you put that in perspective of how much people lost?
Yeah, well, the FDA traditionally says if you can have a drug that allows 5% of the body weight loss, then you can get approved for obesity. So this was 13%. So people were losing that weight on average about 220, 230. They lost 20, 30 pounds on average. And, that is hard to believe. And when you talk to people on it, they come back and they are a new individual. Their mindset is better. They've lost weight. They feel better. They've joined the gym. They start to exercise more. You know, I just put a patient of mine on it, and he wrote me this long email how it's changed his life.
Yeah.
And he said to me, am I going to have to be on this forever? And I said, well, listen, there's a couple reasons why you shouldn't even be answering this question, but that's okay. That most likely you will. And I remind them of what I want to tell all of you is that although these drugs are approved for weight loss and glucose control, they also protect the heart and the kidney. And so I said, you want to be on these drugs the rest of your life. So, I mean, these aren't just small studies. These are studies that specifically took thousands of people with type 2 and they gave them a fake pill, placebo, or they gave them one of these GLP-1s. And they looked at them over 4 to 5 years, and there was a statistically significant, that's a medical phrase for a real difference between the two groups of heart attacks and strokes.
And then recently there was a study that was actually with Ozempic looking at the progression of kidney disease. And this is pretty rare, but they actually stopped the study early because it was so overwhelmingly positive for people, showing that it prevented kidney disease or progression of kidney disease, that it no longer was ethical to continue the study for people that were not getting the drug. So again, that rarely happens, but you know, they have to step in and say, hey, this data is so positive that we can't in good conscience not give it to people now. So blood sugar improvement, weight improvement, but good for the heart, good for the kidneys. So like you're saying, you know, why would somebody want to stop it? But I think it's also important to mention that when people start these medications, whether it's Ozempic, Mounjaro, Trulicity, there are some side effects to probably just expect. That you can get a little bit nauseous, you feel really full. Occasionally people can actually vomit. So if you have tried one of these medications and you're listening to us saying, gosh, like I can't take it because, you know, I had these side effects, there are ways to go, you know, try a different medication, start very, very slow, titrate it up. And if you can get over that first month or so, the side effects go way down. So it's worth kind of retrying if you started it and stopped it previously.
Yeah, that's a great point, Jeremy. You know, for example, Ozempic, the first dose is 0.25. And that is about 40 clicks on the pen, because it's actually a pen. So for almost every one of my patients, I say start off with 20 clicks. Do it once a month for 3 to 4 weeks. If there's no nausea, you go up to the normal starting dose. And I'll tell you what, you never can predict who's going to be sensitive to these drugs. And I think nausea is the main side effect. When you look at the clinical studies where they did everything exactly as they're supposed to do, there's a very small percent of patients that drop out due to nausea, but no one likes nausea. And that is the main side effect. So start low and go slow. I think that's the key. Now, you mentioned the FLOW study, which was looking at Ozempic, reducing the progression of people with type 2 that had chronic kidney disease. That's huge, because one of the things we'd like to turn to now is the development of these, you say them so fast, SGLT2 inhibitors.
So this is topic 2. So topic 1 was these GLP-1s, Ozempic, Trulicity, Mounjaro. Topic 2, SGLT2 inhibitors, like Farxiga and Jardiance. And what do they do, Steve?
He loves to recap. I love it. You know, you frame it up. That's important. Yeah, now these medications started off with a lot of concern in the medical area. Oh, it's going to hurt the kidneys. These drugs work by changing, ready for this, folks, the renal threshold for glucose. So you take a normal individual, they eat a hot fudge sundae, their glucose gets to like 70 or 90, and right away, the body says, I'm getting rid of all this excess sugar before it raises the blood sugar, and it goes out in the urine, and you pee out glucose. But in type 2 diabetes, for some reason, add that to the list of abnormalities we've discovered, that the renal threshold is like over 180, 200. So what your body should be doing is getting rid of sugar at a much lower glucose level. No, it won't get rid of it until you get really high. And that's why you normally see sugar in the urine in people on this class of medications.
So that's how it works. It basically tells the kidney, hey, let's start dumping some sugar into the urine. And so when you're purposely peeing out sugar, well, guess what? That's less in your blood. So your blood sugars come down, and you pee out about 100 grams of glucose a day, which is about 400 calories or so.
Yeah, it's a whole handful of sugar cubes, actually.
Well, I always tell people when I do like my spin class or Peloton, I'll tell you like how many calories you burn, and it's like usually around 400 or so. So this isn't on label, but I say it's like a spin class and a pill, and one a day. That like that's that many calories.
Yeah, you're right. It's one pill a day. You take it in the morning. Might as well mention the side effects now before we get into some of the really nice advantages of it. And some people notice that they urinate more after they take it. I find that occurs in people with high A1Cs to start off with.
Yeah.
And so that's why we recommend take it in the morning. And I can't think of any other major side effects.
Yeah, I mean, like people can have more, like women can have more yeast infections, especially when they start it. I tell people that you won't notice like you're peeing more, or it smells funny, or you're waking up at night.
Right.
People generally just don't notice anything.
Yeah.
Yeah.
And there, if you read the quote unquote package insert, that's the list of side effects that doctors read. There is a condition called euglycemic ketoacidosis. It's rare in type 2s. It occurs in type 2s who have very poor control on insulin. Something to talk to your doctor about.
Yeah, and just like the previous class of medications, these have been shown to be extremely beneficial for protecting the heart and the kidneys. So there is this movement, which we're going to talk about kind of in the next final topic, to using these drugs actually first. So it's always been the kind of the algorithm for treating people with diabetes is you start with diet and exercise. Who even knows what that is? Like, how do we explain that to people? If that doesn't work, you go to metformin. When that doesn't work, then maybe you go to these medications. And you're always just kind of waiting to fail. Okay, let's do diet and exercise until you fail. Which, by the way, type 2 diabetes is kind of a progressive disease. So over time, people do need more. And you're constantly feeling like, well, I used to be able to handle my blood sugars with just, watching my carbs. Now I need metformin. Now I need these drugs. We need to change the paradigm. I firmly believe that when everybody is diagnosed with type 2 diabetes, regardless of what their blood sugar is, their A1C, they should be on both of these medications, an SGLT2 like Farxiga or Jardiance, and a GLP-1. And I think we're getting there.
Oh, good. We covered our third big topic right now. That's fine. We can do it at any order we want. But I think that
we went 1, 2. Like, what comes next?
Well, I haven't finished 2 yet.
Okay, back to 2.
No. I want to let's finish this because I think it's important.
Okay.
I agree with Jeremy, but there's limitations on who can pay for this medication. But it's true that the official recommendations from the American Diabetes Association to doctors that if the first thing you're supposed to ask your patients, or when you evaluate them, do they have heart disease and do they have kidney disease? And if they have heart disease, you give either a GLP-1 or an SGLT2. And if the glucose isn't under control with one of those, then you add the other. And that's a 1-2 punch. I've heard you say that before. And but very specifically, if there's kidney disease at the current time, it's typically SGLT2 inhibitor like Jardiance and Farxiga. They both have tons of data. And that's the last thing I wanted to mention about this is that, we talk about Ozempic just being shown to protect the kidney, but we know for sure that that SGLT2s, they're both approved to prevent the progression of kidney disease. This is huge because in the olden days, not that long ago, all we had was a certain type of blood pressure pill, an ACE inhibitor, or what we call an ARB, like candesartan or Monopril. There's a whole bunch. They're generic now. So that was only one area to prevent the progression. And it was not very strong. So then we came along SGLT2s. Then we won't get into these details, but we talk about it in other talks. There's a medication called Corindia. And now, we have Ozempic. So we now have 4 pillars of therapy to prevent the progression of kidney disease. And you know what these two classes of drugs, the GLP-1s and SGLT2s, it made us much more communicative with our partners in nephrology and cardiology. We're sharing medications now, and it's kind of like a race. If you have a patient with chronic kidney disease, who's going to start it first? And so it's really been a major game changer. And the other thing too is, in terms of heart disease, it's primarily congestive heart failure. That's the most common cardiac abnormality in people with type 2.
And I think just kind of backing way up of why do we do all this in people with diabetes? And it's really that heart disease is the #1 killer. Kidney disease, going on dialysis, we want to avoid those things. So now we have drugs that can really help, keep people healthy, have them control their blood sugars, which also helps with their eyes and their feet. So And I said it, in our type 1 talk, but I mean it. I am legitimately jealous that these drugs are not approved yet for people with type 1 diabetes because of all these benefits. And I have all these type 1s coming and begging, can we fight with my insurance company to get me one of these medications? And, we do, and sometimes it goes through, sometimes it doesn't, usually not. So if you're listening, you have type 2 and you can use these medications, for God's sakes, take advantage of it.
Yeah, we can't emphasize that enough. And someday you'll go back and look at the archives of the TCOYD productions and you're going to see, hey, they were right. This stuff is amazing drugs that's changed the face of treating type 2 diabetes. Well, now we have 1 minute left.
Okay.
Let's talk about once weekly insulin.
Yeah, so real quick, we've had basal insulins for a long time, like Lantus, Tresiba, Toujeo. You take them once a day, and they're background insulin, and they work great. But now companies are working on once a week basal insulin. So if you are on something like that, very likely in the next 6 months or so, we're looking at hopefully getting one of these approved. So, it's less injections, maybe helps you stay on board with it. But if you have a once a week, basal insulin and a once a week GLP-1, it's just making it easier for people with diabetes to take these medications, stay under control, and not interfere with their lives as much.
Yeah, well, they'll put those two together as well. One injection, GLP-1 and basal insulin, just like Soliqua and Zoltify, which are Lilly and Novo products that mix a GLP-1 with basal insulin, but they're once a day injections. Well, I want to finish with a famous quote by Sir William Osler that I learned from Bill Polanski. The way to live a long and healthy life is to develop a chronic disease and then take care of it.
Like we're doing.
Like
we're all trying to do. Well, thanks for listening to our transformation talk. And Steve, you can go put your Iron Man gig back on.
Oh, I can't wait.
Right.
Transformers.
Thanks, everybody. Bye.